All right. Hi, everybody.
Is this the same PowerPoint?
It is the same PowerPoint as last time. It is the same PowerPoint from Friday. I just put a different cover on it for the video. Hope that you are all doing well. If you look at the course schedule, you will see I've got a couple of assignments due after break. They are both posted on Moodle. One of them is about clinical immunology. One of them is about vaccines. They're both up. I think they're both pretty self-explanatory. There's one thing I will say about the clinical assignment, and this just might be like because I'm old and have assigned this a few times and get cranky kind of thing. So I've taken some cases out of a book about immunology cases and sort of describe them and ask you a couple questions like, what is a gene that is mutated? I'm looking for a gene, not like a group of genes. But also when I put this assignment together, I picked cases that could be answered using genes we learned about this semester. If you actually go online and find the answer key to the book, you sometimes find a list of a gene that we didn't learn about this semester. So don't give me a gene we didn't learn about this semester as the answer. Like every single question can be answered with a gene, something we learned about this semester, and with one gene we learned about this semester. So that is what I'm looking for. I'm not looking for your Googling abilities. Again, done this one a few times. The goal here is to help you kind of learn some stuff about immunology. Today I'm going to, so just remember those for next week. Today I'm going to finish talking about hypersensitivity. And if you recall, we have already talked a little bit about the fact that there are kind of four big mechanisms that immunologists talk about as being types of hypersensitivity reactions. When I think about hypersensitivity, I'm usually thinking about allergy. And very commonly, people think about this type 1 hypersensitivity reaction and allergy, which we talked about last time. But there are three other types of hypersensitivity reactions that have three different mechanisms. And we're going to talk about those mechanisms today. One of the things that's really useful about thinking about these three mechanisms is that you can see that these mechanisms also are the same mechanisms that we're going to see for different transplant rejection reactions that we'll see after break, as well as the mechanisms for certain autoimmune diseases. And it looked like, as I was flipping through these slides, it does look like there are a couple places where I give you some autoimmunity examples in here along with the allergy examples as I'm talking about the different mechanisms. So you will see that today. So like I said, we talked about type 1 a bunch last time. If you remember, type 1 had the mediator of IgE antibodies and mast cells. And the key thing about type 1 hypersensitivity was that it was immediate. So that's the immediate type hypersensitivity response. So we're going to move first into thinking about type 2 hypersensitivity today. And with type 2 hypersensitivity, just like you saw with type 1, antibodies are really key. Here, the antibodies are either of the IgM or IgG isotype instead of IgE. So you can see at the top that we've got IgG or IgM being really key. Spoiler, when we get to type 3 hypersensitivity, you are also going to see IgG or IgM listed as the effector. And so you're going to want to pay attention to the other key piece of this, because this is the thing that differentiates type 2 and type 3. The big difference between type 2 and type 3 is actually the antigen. not the antibody. In both cases, we have an IgG or an IgM, but we actually have a difference in the antigen between these two types, and that results in a different mechanism happening. And so the key thing about the antigen in a type 2 hypersensitivity response is that the antigen is a cell surface antigen. So you can see this here. We've got a cell surface antigen, so you can see our antibody is binding to this antigen that's on the surface of some kind of cell. When we get to type 3, the antigen is going to be free and not on the surface of a cell. So it's really key here that we have an IgG or IgM, and we see that on the surface of the cell. And the key thing that is going to happen in a type 2 hypersensitivity response is that because we have antibody binding to this cell surface antigen, something bad's going to happen to this cell. This cell that had the antigen on its surface is going to get killed. In some ways it can be complement, sometimes it can be ADCC. It can actually be a few different things. The idea is we have a cell surface antigen and we're killing the cell here with IgG or IgM. So when we think about type 2 hypersensitivity reactions, there are a couple of famous examples. Both of them actually involve red blood cells, and in fact you can see here red blood cells are a common target in a type 2 hypersensitivity reaction. And so the first example we have to think a little bit about is with blood group antigens. So you can see two little red blood cells here, and those red blood cells have different molecules on their surface. One thing that they will have that's different on their surface is they might have this protein called the Rh antigen, or they might not. And that's going to be dependent on whether or not a particular gene is encoded in those. And so that will be lead to red blood cells that are either Rh positive or Rh negative. So when you think about your blood type, there's either there's a plus or a minus. That's part of it. That's based on if you're Rh positive or Rh negative. In addition, when we look at red blood cells, they have a bunch of carbohydrates on the that are part of other proteins. Those carbohydrates have sort of a string of carbohydrates that are coming off a lipid or protein. So you can see this little blue wavy thing. That's the lipid or protein. And then you can see there's always an N-acetylglucosamine. There's always a galactose. There is always an this was N-acetylgalactosamine. There's our galactose. Then there's an N-acetylglucosamine. Then there's always another galactose. Then there's a fucose. In some people, there is an enzyme that adds another N-acetylgalactosamine at the end to this sugar. So there's purple thing. In some people, the enzyme is different and it adds a galactose to the end of this chain. In some people, we don't add any sugar to the end of this chain. Those are known as, those different sugars are known as different antigens. This one is A, if you have this sugar added. This one is B, if that sugar is added. If no sugar is added, it's O. And basically what you want to note is that these are all sugars on the surface of red blood cells. Rh is a protein. And as we will kind of think more about as well when we think about transplantation, individuals who have blood type A, in them, the A antigen is a self antigen. And so they don't have antibodies against A. So they have the A antigen on their blood cells. They don't make antibodies against A, so they have no anti-A. They do have anti-B. I'll tell you more about that when we get to transplantation, why they have anti-B. And you can see that so on. And so everyone, has different blood groups. This is sort of a pretty straightforward key thing. And the situation that I want to tell you about in this first scenario actually has to do with Rh plus and Rh minus. And this is one of the very famous examples of a type 2 hypersensitivity response. This is a disease called erythroblastosis fetalis, otherwise known as hemolytic disease of the newborn. And what will happen in this disease is that we'll have a mom who is Rh minus. And so if we have a mom who is Rh minus, has she ever made an is Rh a self-antigen or a foreign antigen to her? It's a foreign antigen to her. Has she ever had an immune response to the Rh antigen? No, because she's, right? But it's possible that she could have an Rh positive fetus. Perhaps her partner was Rh positive, gave the fetus the Rh gene, and so she has an Rh positive fetus. And so we could imagine a fetus that has the Rh antigen in a mom who is Rh minus. At some point during delivery, mom is going to get a little bit of exposure to baby's red blood cells. And when that happens, mom will have some Rh binding red blood cells or B cells. They will have been floating around mom's whole life, doing nothing, having seen nothing. They will have been naive her whole life. And now mom's B cells that bind to the Rh antigen are going to get a signal. They're going to differentiate. They're going to make plasma cells. They're going to make memory cells. Mom is now going to have a lot of antibodies against Rh in her body. So what happens to mom if she's just walking around with a whole bunch of anti-Rh antibodies in her body? Does anything happen to her? No, it's a foreign antigen. It's not in her body. She's got some antibodies against it. Big deal. Like, no one cares. But if she now carries another fetus that is Rh positive, second fetus that's Rh positive, these antibodies are going to be, nice, active, perhaps class-switched antibodies that bind IgG. What happens if mom now has lots of nice antibodies against Rh that are IgGs that she previously made as a result of that exposure from the first pregnancy, like at delivery? Yeah.
It's going to attack red blood cells of the second fetus?
Yeah, those IgGs are going to go across the placenta. Those IgGs are going to go into the fetus. See, here you can see those antibodies going into this second baby. And those antibodies are actually going to lead to destruction of the baby's red blood cells. And so this baby we're actually going to have no red blood cells in this baby while the baby is developing in mom. And as a result, the baby is going to be born severely anemic. There are also going to be some complications that are coming from issues with some of the compounds in red blood cells going into circulation, and it's all sorts of bad news. So we've got a sick baby here, and that is sad. And this is basically what is happening to the baby's red blood cells in this situation is a type 2 hypersensitivity response. We have this cell surface antigen of Rh that is being bound by these antibodies and leading to the death of these red blood cells. It can be by complement, it can be by NK cell lysis. We actually kind of don't care. Happily, we have a really good way that we can prevent this disease. So this disease doesn't happen as frequently now. So typically now, what happens is that mom and baby are both tested at some point to see if they're Rh positive or Rh minus. And if we realize, hey, look, mom's Rh minus, baby's Rh positive, there is a possibility of this reaction happening. So we see this happen during the first pregnancy. We're like, this could have happened. We actually then start treating mom with something called RhoGAM. RhoGAM is really just an antibody that binds to these B cells, in the fetal B cells, and makes it so they can't bind to mom's naive B cells. So basically, baby's red blood cells get covered with antibody because we've treated with this antibody. And this treatment is happening in mom. So we're not like killing baby's red blood cells. But what we are doing is we're making sure any of mom's B cells that would have been activated by this antigen can't get activated. So our B cell can never be activated in this mom. And so then she can be pregnant in subsequent pregnancies without making this reaction. You can also see the details of sort of RhoGAM working here. So you can see that normally we would have this baby's red blood cell with the Rh antigen. It would interact with this naive B cell. Then we'd get a memory B cell. We'd get these secondary high affinity responses. We'd start to kill the baby's B cells. So what we do in mom is we treat mom with this antibody that's going to bind to any of baby's red blood cells and actually turn off B cell activation. So any B cell that starts to get activated will get this negative signal through this RhoGAM molecule that's also binding. And we will keep mom's B cells from ever getting turned on so that she never makes this response to Rh and she can have subsequent pregnancies with an Rh positive fetus. Yep, Paige.
When are these treatments and I assume they probably do tests and stuff done?
I think they're done pretty late, but as I'm standing here, I was thinking to myself, I'm like, oh, I don't remember what week, where exactly it is. I think it's pretty late, but I don't know off the top of my head. Yep, David.
RhoGAM is applied in the second pregnancy, right?
It's actually usually applied in the first pregnancy as well to sort of block any B cell activation.
Okay.
Potentially, at delivery, you want to make sure you block.
Main fetal death occurs during the second.
Yeah, the goal with the RhoGAM is to make sure the second pregnancy goes okay. The other really famous example of a type 2 hypersensitivity reaction involves penicillin. As I told you last time, there are examples of hypersensitivity reactions to penicillin of all 4 hypersensitivity types. So we can't really think of penicillin as just going with one of these types. But I am going through the example of penicillin with a type 2. Here. And so again, you can see with our type 2, we've got IgM or IgG that's being made, and we see this disease that's called hemolytic anemia. You can see penicillin in this image, and so penicillin is the compound that's shown in the middle of this image. And what your textbook is trying to show you here is that there is this particular bond in penicillin that is particularly reactive. When penicillin is around the appropriate bacteria, this reactive bond interacts with a bacterial protein and makes it so that that bacterial protein no longer works. So yes, this is the transpeptidase that's involved in peptidoglycan cross-link bridge formation. We don't care about that right now. We just know that normally penicillin has this reactive bond, it reacts with bacterial protein, and that stops the bacterial protein from working. However, Sometimes that reactive bond can react inappropriately. Sometimes that reactive bond can react with other stuff. And in particular, sometimes that reactive bond can interact with proteins on the surface of red blood cells. And so now you can see this red blood cell with stuff attached to it. All of these pieces of penicillin. That is basically a new antigen on the surface of this cell. So this cell has been modified and has a new antigen on its surface that it did not have before. We can now, and so here you can see, here's our red blood cell. It's modified because it has penicillin antigen on it. It normally would not have little circles with a P, but it's been modified so it has them. If antibodies happen to bind to that, then that red blood cell can get killed either by complement-mediated lysis or it can actually get killed by phagocytosis from macrophages. And so again, our patient is going to end up with anemia, not enough red blood cells, and that's going to be a problem for this patient. This, of course, obviously does not happen in every person who gets penicillin treated, and why exactly it happens in some people and not others is not particularly certain. All right. So the third big type of hypersensitivity reaction is a type 3 hypersensitivity reaction. And again, with our type 3 hypersensitivity reaction, we're seeing antibodies causing problems. And again, these antibodies are often IgGs or IgMs. So type 1 was IgE antibodies, both type 2 and type 3 are IgG or IgM. But the difference with type 3 hypersensitivity is that the antigen, which you see here as a little green oval, is a secreted protein, sometimes referred to as a soluble antigen. Could also be a soluble carbohydrate or lipid or nucleic acid. It can be a soluble whatever. It's a thing that's not on the surface of a cell. So killing the cell can't be the outcome because there's no cell to kill. Instead, what we're going to see is the formation of something called an immune complex. Type 3 hypersensitivity reactions are also sometimes known as immune complex disease because the immune complex is the problem. And so an immune complex is something that you can see right here, where you have multiple antigen molecules and multiple antibody molecules coming together to form a big complex. So as you can kind of see here, each of our antibodies has 2 antigen binding sites, and they're identical. That means that each antibody could bind to multiple antigens. If you look at, you sort of can't tell it in great detail here, but realistically, each of these antigens has 2 epitopes. Because in fact, they can bind to more than one antibody. So the epitope must be repeated more than once. So there must be, curvy epitope here and curvy epitope here. And so because of this sort of repeated epitope, antibody binding more than once, you can get this big complex of multiple antibody molecules, multiple antigen molecules binding together, known as an immune complex. And that immune complex can lead to disease. You can sort of see this here as well. Immune complex formation really requires you have just the right amount of antibody and just the right amount of antigen. If you have lots of antigen and only a little bit of antibody, then each antibody will bind to some antigen and nothing will really cluster together. You won't really see any big clumps of anything. If you have lots of antibody, a little bit of antigen, you'll see that we mostly have everything kind of free. But if you have sort of this just the right medium amount of antigen and antibody, you're going to get this huge molecule where all sorts of antigens and antibodies are binding together. And that thing can basically clog up or clump in different body locations. This is going to flow freely through a vessel, for example. This is going to flow pretty freely through a vessel. This big complex of all of these things binding together is going to be clumpy and is potentially going to lead to clogs and things. And that is the immune complex, where we have this higher order structure of many antigen and antibody molecules bound together. Yes?
Is this considered cross-linking? No.
Cross-linking usually is when we're thinking about a receptor on a cell. Then we're bringing them together to get signaling. So I would say no, but I could totally see where you're coming from on that. And so what the graph at the bottom is showing you is that, if there's too much antigen, this doesn't really work. If there's too much antibody, it doesn't really work. But if there's sort of just this middle amount of both, then we're going to see these antigen-antibody complexes form. When immune complexes form, there are a bunch of different problems that can happen. So here we can see immune complexes happening in tissues, and that basically leads to inflammation happening in the tissue, because we're now going to start having complement deposit here. We're going to start having other types of phagocytes acting here. We're going to see degranulation here, all of those types of things. And so we're going to see quite a lot of inflammation happening. But more importantly, if those immune complexes are circulating, they may start inflammation in vessels, but they also might just block the vessels. You can imagine them as a physical block in the vessels. This weekend I had to get all the hair out of the drain of my shower because I didn't want it to block the flow of water through the pipe. It's the same thing, that these immune complexes would be blocking the flow of blood through the blood vessel by clogging it up. Sometimes, so this idea of immune complexes going in vessels, potentially leading to inflammation and damage of the vessel, but also just blocking the vessel, is bad. Sometimes you will also see this exact same blockage happening in things like alveoli, where again, you're going to see that little delicate area where you're supposed to have blood flowing and an air exchange is going to get clogged. We also can see this sometimes under the layer of skin and get a weird little rash. You can sometimes see it in joints. And the other place where sometimes we see it a lot is actually in the kidney, in kidney filtration. And so it actually blocks kidney filtration and blocks kidney function. And so these immune complexes can cause quite a bit of issues. So I want to tell you about one example of a type 3 hypersensitivity response that is really kind of hypersensitivity. It's a foreign, innocuous thing. But then I'm also going to tell you briefly about 2 autoimmune diseases where immune complexes play a really big role. So we're going to see some examples of immune complexes. And the very famous hypersensitivity reaction example of immune complexes is something called passive antibody therapy. And we've talked a little bit about passive antibody therapy before, but there is one piece of it we didn't think about that we need to think about now. And so we talked about this when we talked about antibodies way back earlier in the semester. That one of the things that we can do if we want to treat individuals who have various infections, also true if individuals have some other types of conditions, we can actually take antibodies from another individual who has already made those antibodies. So, they've already done class switch. They've already made plasma cells. They've already had a whole immune response. They've already made lots of antibodies. We can take those antibodies from that previously immune individual and inject them into our infected individual. So then we don't have to wait around for that person's B cells to make a response and make class switch and plasma cells and all that. We can protect them right away and have that person recover. And so that's what passive antibody therapy is. This has been something that people have been doing for, a couple hundred years. Or at least 100 plus years, in terms of thinking about protection from different diseases. And in fact, if you think about monoclonal antibody therapy that some people got for COVID, it was this. They made COVID, instead of making them in a person, they made them in the lab and were giving people COVID antibodies. One downside of passive antibody therapy, which we will see next time, is of course this individual who receives the antibodies passively did not make their own antibodies. It was passive, not active. As a result, if they get infected again, they don't have a memory response. They didn't make they don't have memory B cells because their personal B cells didn't actually participate the first time around. They didn't have to participate because these other antibodies were put in place. And so they're not going to have a memory response. Potentially, we might have to give them passive antibody therapy again because they're still not protected. And you can see on the right a table that lists some of the situations where passive antibodies are used. When we talked about this earlier in the semester, we did talk about some of the cool ways people are now making humanized antibodies and all sorts of like fancy antibodies in the lab. But these are sort of some of the originals, and this is still very much how it works for some of these cases. So if you look at this, you can see that one of the examples here is a black widow spider bite. And if you look at the black widow spider bite, it says that you are treated with horse antivenin. What that means is you are treated with antibodies from a horse. Basically what they've done here is they've made antibodies in a horse. One of the reasons why this is useful is because horses are big and have lots of blood and thus make lots of antibodies. So we've got these antibodies made in this horse, okay? So I want you to imagine that you get a black widow spider bite and I treat you with passive antibody therapy with horse antivenin. Now let's imagine you get a second black widow spider bite. A, I will have questions about your life choices. B, what's going to happen after that second black widow spider bite? Are you going to have B cells to help you, your own B cells that are memory and that are ready to make antibodies against this venom? No. So what are we going to have to do? Black widow spider bites kill you fast. What are we going to have to do in order to treat you? Here.
Another one.
Huh?
Another one?
Another what?
Like, passive antibody therapy?
So you're going to have to get passive antibody therapy again. You're going to have to get horse antivenin again. But there's a problem now. Because remember, we're giving you antibodies, right? What kind of molecules are antibodies?
They're proteins, so then you make antibodies and responses against that.
Yeah, so the first time you got that black widow spider bite and I gave you antivenin, I was giving you a whole bunch of horse protein, technically horse antibody, but I was basically injecting you with a whole bunch of horse protein. When I inject you with a whole bunch of horse protein, it's a foreign protein to you. Your body is actually going to make antibodies against horse proteins. Your body is now going to start making antibodies against horse antibody. If any of you do Westerns and you use things like anti-goat or anti-mouse, that's where you just have antibodies against the antibodies from some other species. So you are going to make a whole lot of anti-horse. And now if you get treated again with this antivenin, what's going to happen? I'm going to now give you this horse antibody again to try to cure you of your black widow spider bite. What's going to happen to you? Yeah.
Now I think the biggest worry is the horse antivenom as opposed to the black widow spider bite.
So why are you worried about the horse antivenin?
Because you have a whole lot more of that than you do of the black widow spider bite.
Okay, but why is it going to hurt you? Why, it didn't hurt you before?
Because now your body's made a response to it, considering it as a foreign antigen.
Yeah, so Miles, what were you going to say?
Oh, I was going to say pretty much the same thing.
Okay, what were you going to say, Emily?
It won't be able to find the target of the venom.
No, you're going to actually have this antigen is horse antibodies. The horse antibody is the antigen in this case. We're going to put a whole bunch of antigen in, and you're making more and more antibodies against it. So your antibodies are red, the horse antibodies are yellow. As you look, at some point, you're going to get to this situation where you're going to have the perfect situation to make immune complexes, where you're going to have great big clumps of antibodies bound to other antibodies that make a big clump that looks like this. And so you're going to have your antibodies like in blue, and these red things are going to be horse antibodies, and you're going to make this giant clump of antibodies bound to other antibodies in this huge thing. That's an immune complex. And that's potentially going to lead to inflammation. That's potentially going to deposit in your blood vessels, lead to issues with blood vessels, and on and on. This disease is officially known as serum sickness. And it is a complication that happens when someone is given passive antibody therapy. And so you can see, maybe if I go to the right screen, you can see some examples of passive antibody therapy serum sickness issues here. You can see sometimes people will end up with vasculitis and the immune complexes will be depositing in the blood vessel walls. Sometimes we'll see nephritis where those start depositing in glomeruli. Sometimes we'll deposit in joint spaces. Sometimes you'll deposit in the skin, which you can see examples of here. Sometimes there'll be deposition in the alveoli that will lead to issues with blood vessels. And so we can see a number of different manifestations of serum sickness. All of these things are issues that are coming from passive antibody therapy, type 3 hypersensitivity response. Yep, Nadia.
So does that always happen with passive antibody therapy? Because like, is the benefit that much better?
Well, so again, this is the second time you get passive antibody therapy.
Right. Yeah.
And so, hopefully, most of these things that you're getting passive antibody therapy for are not things that are likely to happen to you very often in your life. So hopefully you're not getting 2 black widow spider bites. Yeah. Like, after you played with black widow spiders the first time, what are you doing?
Like something like tetanus could be common.
But you're probably not going to get tetanus twice. You might get a tetanus vaccine twice, but then it's actually, do you then unvaccinated step on a rusty nail twice? Yeah. Right?
Rabies twice.
And so I put this slide back up, and this kind of gets to Nadia's question. So in a past year, I had a student who had a very serious question at this moment. And you're going to laugh at this question. And yet it's a great question immunologically, even though it sort of feels like a silly question. So student asked me at this point, okay, so get my black widow spider bite, get my horse antivenin to treat me for my black widow spider bite. If I get another black widow spider bite, would I be okay if you treated me with antibodies from a cow? So now let's imagine we don't make the antibodies from a horse. I think he actually wanted to make the antibodies from a raccoon, but I don't remember exactly where we were making. Some other species we make those antibodies from. Now what's going to happen, Nadia?
The same process over again?
No, because you haven't. Now if you switch the species for the second time, you don't have anti-raccoon or anti-cow antibodies in your body, so you're going to be okay again. So it's going to work. If you were to keep switching species and keep going to different species who you don't have antibodies against their antibodies, then you'd be okay. It's just that manufacturer-wise, we do not do that.
We have backups.
We don't have backups, and now when we use monoclonal antibody therapy in people, for most of the monoclonals that we use humanized antibodies. So they've basically been made so that they don't induce this kind of reaction at all. And so that then you can have them as many times as possible. So like my dad has been on a monoclonal antibody for many years that he might inject every few months. And he doesn't worry about passive antibody therapy because in the lab, they have heavily modified that antibody to give it the human constant region. So it's a humanized antibody. And we talked about humanization a little bit when we talked about antibodies before. Yep, Emily.
So that's what I was going to ask. All the monoclonal antibody drugs that we talked about
Are humanized or are pretty heavily modified. They're not all totally humanized, but they are all usually modified enough so that we can get around this. Yes, Jess.
Wait, so is this the same case for like IVIG for like post chemotherapy?
With IVIG, you're getting it from other people.
Right. So you're getting it from a bunch of other people who have made antibodies and it's kind of pulled together, and then that's given to you.
Yeah.
How is your body?
Because the idea is that everybody's is going to be a little bit different, and you're not going to get enough of any one to make a response. In the way here, you get a response to anti-horse, because horse is more horse is more different than you, and you're getting a whole lot of antibody just from Mr. Ed. So you're getting a lot of that one foreign protein, and it's really foreign. Whereas if it's a pool of many people, there's no one that's going to be so strong that you're going to get so much of it because it's not going to be that foreign.
Okay.
Does that make sense? Yep, David.
Instead of getting the antibody from an animal, could
Mm-hmm.
you just extract the antibody from a previously infected human and then just inject that into another person?
That has been done, that is done sometimes in some cases. The issue, of course, so the reason why we do it is, for example, in early COVID, if you go back and look, if you look at newspaper articles or things online, they were asking people who survived COVID, like in April 2020, May 2020, to go give blood, because they were going to do exactly what David said. They were going to try to take antibodies from them to give to COVID patients. The trick, of course, is that ethically, people are not okay with us, giving people black widow spider bites so that we can harvest antibodies out of them. Whereas ethically, we can do that with a horse. And so the issue with human is you can't always inject people with whatever in order to get whatever antibodies you want. That's not, an ethically possible thing in all cases.
But like hypothetically, if someone got like 500, I don't know, snake bites.
There is that guy. There was that guy. I don't remember the details, but I think actually they are trying to look at his antibodies from him. I guess you could, but also at the same time, that guy probably doesn't have you're not going to get like liters from that guy. So he's probably not going to be able to give you something that's going to help very many people. Unless, again, there's some lab things you could do, but easily no. Yes, Nadia.
Is this like kind of similar to like people wanting to, if you had Lyme's disease, like to donate blood because of something like that?
I am not familiar of the details of that. So as I mentioned, there are also a couple of different types of immune complex mediated autoimmunity. So this idea of immune complex disease is not just allergy, hypersensitivity type of thing. Here you can also see, immune complexes happening. There are a lot of different autoimmune diseases where we see immune complexes being of particular importance, but there are two that are really famous. One of the most famous is SLE, or systemic lupus erythematosus. So I know you guys had to do an assignment that was due last week where you had to listen to a podcast and answer some questions. One of the secret reasons why I have you do that is I like the idea of you guys understanding, like, you're asking questions that are similar to what the scientists are asking, and like you shouldn't feel dumb when you have questions, and like you in fact are sounding very much like they are sounding when you were talking about a lot of these papers. Like that's part of what I'm trying to get you to get from that assignment, and so I hope that you saw that. If you happen to listen to the episode of TWIV that was released yesterday, which we recorded on Friday, we actually talked about this amazing paper that talked about lupus immunology, which I will say a little bit more about on one other slide, because in fact there's one slide I have in here that I really wished I had during that podcast discussion. But lupus is very much an immune complex mediated disease. And so the idea with lupus is that patients have autoantibodies that are binding to self-antigens. Those self-antigen, and then we have immune complexes being formed. Those immune complexes can sometimes happen in the lung, can sometimes happen in the heart, can sometimes happen in the kidney, can sometimes happen in the joint. We can often see a rash that's shown here. It's known as the butterfly rash. But we see completely different kind of symptoms in most lupus patients. And part of this is because the immune complexes are depositing in different places in different people. And so you can see a variety of some of the issues that happen here. Sometimes lupus is referred to as the great imitator because many of the ways that you actually diagnose lupus is by exclusion from other things, because it just has so many weird symptoms of inflammatory disease of so many different things. So basically it's sort of like it's lupus if it's not anything else. You can also, if you go online and you look for YouTube clips from House, it was like a joke on House that the younger doctors would always like decide whatever random disease they were seeing was lupus, and then he would yell, "It's not lupus!" And you can see there's like a compilation of him just yelling, "It's not lupus," over and over again online. And so lupus has a lot of different symptoms, looks really different in a lot of individuals. That's all down to where the immune complexes are happening. And so you can kind of see, you can sort of imagine how all this can lead to a lot of inflammatory issues in a number of locations and things like that. The big question that you might ask is about what is the antigen that these immune complexes are binding, because this makes it seem like it's in a lot of places. You might wonder, you know, is this antigen something that your body has that you should be worried about? And so some of the antibodies that are seen in lupus patients commonly are listed here, which include things like anti-DNA antibodies, anti-histone antibodies, anti-RNA antibodies, anti-phospholipid antibodies, anti-SNRP antibodies, which are part of the nucleolus and splicing, and anti-ribosome antibodies. And in fact, the way that the other big diagnostic for lupus is they just take your serum, they take the antibodies and they put it on cells in culture and see if your antibodies bind to the nucleus. There's called an anti-nuclear antibody test. Do you have antibodies against nuclei? And so you can, and so this is actually showing some of these deposits and ANAs in lupus patients. And so again, what's happening here is that we have a number of different nuclear components that you can imagine are in lots of different places throughout the body of these individuals. You might imagine as cells might die, as cells always die in every individual, there's going to be some loss of some of this stuff, potentially binding to antibodies, and you're going to get some really large immune complexes that may deposit in different locations. And so you can sort of see how immune complexes could lead to disease here. Emily, you had a question?
It's just been a while since we talked about humoral immunity. I
Uh-huh.
just have a question about
Yeah.
how, like, if there's an antigen kind of floating in your blood,
Mhm.
and antibodies come to it,
Mhm.
how is, like, and then when you say inflammation, do
Mhm.
you just mean, like, the antibodies are there, or, like, how does it lead to, like, something like cytokines?
So that could activate an Fc receptor on a macrophage or some other cell that might phagocytose, but also might secrete some cytokines. It could lead to things like complement deposition in the C3a and C5a. So there could be a lot of sort of downstream things that are happening.
Now that the macrophages
Yeah.
use the antibodies.
Yeah,
and they-
yeah,
they
exactly.
would secrete cytokines.
Yeah, yes, so that could be part of it. Or like I said, complement could be another big part of it. This paper that came out this month that we talked about on Friday, that is a really fabulous paper. If we had more time, I think I have to cut a topic from next week because I'm a day behind. So if I had like an extra day instead of negative a day, we would talk about this paper because it's pretty fab. Well, I mean, it's okay. It tries to say why so there's a virus that 94% of people are infected with. And the idea is that, EBV, and the idea is that in some people it causes lupus and in other people it doesn't. So why does it cause lupus in some people? And there has sort of been this rumor that it caused lupus in some people but not others. But if 94% of us have it, why don't we all have lupus? And so sort of like how that link worked was what this paper is doing, and it's spectacular. But a big part of what they saw in this paper was this phenomenon of epitope spreading. So what would happen is they might see a situation where there would be, say, a B cell that binds to one of these self-reactive antigens that gets activated inappropriately. When that B cell binds to its antigen, which you can see here is this red histone protein, it can internalize this whole complex of chromatin. And that's going to have a bunch of physically linked DNA and different histone proteins. It's going to endocytose that. It's going to break that up into a number of different peptides, and it's going to make some red peptides and some purple peptides and some pink peptides, peptides from all different parts of this. Those are then going to all turn on different T cells, different CD4 T cells, based on which epitope is being recognized. And those T cells can then end up turning on different B cells who might also be responding to different parts of this complex. And so we can see a lot of different anti-DNA epitopes getting spread very easily. I would be happy to talk more about that paper because I thought it was really cool. But instead, I'm going to just tell you a little bit about one other thing. The other really famous disease that involves immune complexes is rheumatoid arthritis. So in rheumatoid arthritis, patients have a lot of joint stiffness with a particular number of joints, a specific amount, certain pathology. You can see rheumatoid arthritis pathology at the top. And in fact, in these patients, we see a particular antibody, which is known as rheumatoid factor. It is an antibody against IgG. So in this situation, you make an antibody against the Fc portion of IgG. As a result, you make immune complexes of all your IgG. You basically take all of your IgG and bind it to this this other antibody, rheumatoid factor, which is the self-reactive antibody. And that is what leads to all of this joint damage because you're getting these immune complexes deposited in so many of the joints. And so this antibody can be found in the majority of rheumatoid arthritis patients, though it, like anti-nuclear antibodies, is found in increasing numbers in healthy controls with age. So that does make it a little bit tricky for diagnostics, but it does seem as though all of the issues with rheumatoid arthritis are also happening due to immune complexes. Yep, Jazz.
Why is this primarily in the joints and like not all over?
I think partially because because the joints are acellular, because you don't have cells right there, you don't have the ability to block complement. And so it seems as though there's a fair amount of complement deposition happening once these immune complexes are induced in the joint. So there does seem like there seem to be maybe some complement issues in some of these patients as well. Yep.
Well, why does morning stiffness dissociate after the first hour? Is it because of a mechanical dissociation of the
I would guess it's a matter of, when the lymph's not moving, you're more likely to start to have those complexes pooling places. And as you start to move lymph around, it's going to pool less, but I don't have an answer. Again, we're in the point of Dr. Barker is not an MD. Yes.
Do you also have, like, are you also immunocompromised because you don't have your, like, IG ready to go?
I have not heard people talk about that. That does make sense as a question. I have not. That is not something that I usually hear discussed.
Maybe it's like not enough.
I don't have a great answer for you. So then our final type of hypersensitivity response is the type 4 hypersensitivity response. Just like some of the others, the type 4 has another name. So the type 4 hypersensitivity response is sometimes called a delayed type hypersensitivity response or a DTH response. So I often call it a DTH. What that should tell you is that one of the things that's going to be key in this response is going to be timing. And so we're going to see this delayed timing, unlike the timing that we saw for the immediate type hypersensitivity response, which was in minutes. With the delayed hypersensitivity response, as you're going to see in these slides, T cells are the key mediator, unlike antibodies, which were the mediators of types 1, 2, and 3. And so really the reason for the delay is that we have to have the antigen get to the lymph node, and we have to turn on the T cells in the lymph node, and then we got to have the T cells go back to this site. So all the things that we were thinking about earlier with adaptive responses. There are a number of different types of antigens that can lead to a type 4 hypersensitivity response. You will notice some of the examples I'm going to talk about are things like poison ivy and poison oak. You will also notice things like hair dyes, nickel salts, and a number of different microbes. If you, like me, when you wear cheap nickel jewelry, end up with a rash about 2 days later, that's a type 4 hypersensitivity response to nickel. And thus you have to stop wearing cheap nickel jewelry. And that's what they're trying to show actually in the little image here. If you think back to our type 1 hypersensitivity response, it had phases. I told you that the type 1 hypersensitivity response was immediate the second time you saw the antigen. You needed sort of this prep phase first. So there was the sensitization phase and the effector phase. A type 4 hypersensitivity response also has those same two phases, a sensitization phase and an effector phase. And so you see this delayed type reaction the second time you see the antigen. So the first time I wore the cheap nickel jewelry, I was okay. It was only later times where I started to have this problem. And so during that first phase, that first sensitization phase, you are getting that antigen brought into the lymph node, and you are turning on T cells and making a Th1 response. So in some ways, when I think of a DTH response, I honestly say that's just a fancy name for making Th1s to something. Because all you're doing is you are making that type of Th1 response to that antigen. However, and so the first time around, you started out with perhaps a naive T cell, and then you made this Th1 response. The second time you see the antigen, you have memory Th1 cells. And so now that you have these memory Th1 cells, they are going to be able to act really quickly to activate macrophages and induce a lot of inflammatory responses. And so you can see this happening sort of here. So first the antigen comes in, goes into the macrophage. Now we have this Th1 cell. Because it's a Th1 cell, it must have previously been activated. There must have been a previous encounter that made it go from a naive cell to a Th1 cell. So this is our second encounter. It's already a Th1 cell now. And it's going to activate a lot of macrophages. It's going to lead to a lot of inflammation. The process of getting that Th1 cell there and sort of starting to really cause these effects will take about 24 to 72 hours. So with the type 1, the immediate type hypersensitivity response, we're saying usually like 15 minutes. Here we're saying like 2-3 days after you see the antigen. And you can see we get a lot of swelling, we get a lot of fluid coming in, we get redness. We get all the sort of things you think about with that kind of little rash in that area. because of the action of those macrophages that are activated here, thanks to the Th1 cells. So one particularly famous Th1 response is the poison ivy, poison oak response. So in fact, what happens with, so here's our plant. It makes this compound, which you can see here. Yeah, there's a few versions of it. You can also see it happening here. Here's the compound. When you actually have that compound get into your skin, it reacts with a self-protein and modifies a self-protein. So now you have a new antigen in your body. And this new antigen induces a Th1 response. So if you ever have poison ivy, poison oak again, you get this same kind of modification. Now you have these Th1 cells that are going to lead to this rash about 2 days after you come in contact with the plant, because you need the time for the antigen to actually get presented for the T cells to go back to the location. And so that's one sort of famous DTH or type 1 hypersensitivity response. There is another situation where you have had or you have dealt with a DTH response that you didn't know you were dealing with a DTH response. A lot of people get confused about this one in like layperson everyday life. So that's one reason why I like to talk about it. Tuberculosis is caused by a bacteria, Mycobacterium tuberculosis. I know how to talk. One of the issues with Mycobacterium tuberculosis is that it leads to a chronic infection. So when you get that infected with that bacteria, it can live in your lungs for the rest of your life. And a lot of the time it spends chilling in your lungs, just chilling. It and the immune system kind of get to like a détente. And they both are just there doing their thing. So the bacteria is not going anywhere, the immune system is not going anywhere, you just have it sitting there. But you have the possibility that at some point the bacteria could break out and you could start to have active tuberculosis symptoms. While you have sort of that chronic phase of the infection, you feel fine. And so and the key immune response that happens when you are infected with Mycobacterium tuberculosis is a Th1 response. So if you are infected with this bacterium, you are making a Th1 response to this bacterium. So if you are working in a healthcare setting, it would be really bad if you had tuberculosis in your lungs and nobody knew about it, right? You feel fine, you think everything's fine. You're going to go work with a bunch of patients who may be compromised, and someday you could just suddenly start spreading tuberculosis to them, even though you didn't know. So one of the things that we do is we test people for tuberculosis before having them work in a healthcare setting. There are a bunch of situations where you've had this test. It's called the PPD test. It does involve an injection, and so sometimes people think it's a shot or a vaccine or something like that. It's not. It's a test. And so if you think about, if I describe this and you're like, oh, that's the TB shot. No, it's a test. And it's a test that specifically is relying on a type 4 hypersensitivity response. So the idea is what they will do is they will take a particular protein from this bacteria, the purified protein derivative, aka PPD. They will take a protein from this bacteria and they will inject a little bit of it into your skin. If you are not infected with this bacteria, you do not have an activated Th1 response. And so you putting the antigen under your skin is going to do nothing. If, however, you are infected with this bacteria, you're going to get a Th1 response in that spot in your skin. You're going to get a little bump. And it's going to happen in about 2 days. And so you get this bump. They actually have to look at the area of induration and arrhythmia, basically how raised, how red is it. And if you have a particular bump, that means you had previously made a Th1 response to this microbe. This microbe must be in your lungs, or there's some reason why you made a response to this. You need further testing. And it's pretty nice because it's pretty quick and easy and cheap to do this, and only do more intensive testing on people who come back as positive. And so you can see this is why you have to go back after about 48 to 72 hours, because that's how long it takes a DTH response to happen. They put the little bubble under the skin, then they're going to look for whether you have a red and raised mark. And so it's all looking for, have you previously made a Th1 response to this antigen, which generally happens upon infection. Now I say generally, there is a vaccine against tuberculosis. We do not give it in the United States. It's actually a pretty awful vaccine. But it is given in some parts of the world. Some people who are born outside the United States will have had that vaccine. As a result, they always test positive on this. And so they always have to go for the more extensive testing, which involves a chest x-ray. Basically, one of the things we're trying to do is prevent having to give too many people x-rays all the time. Because in fact, when I was in grad school and we had people who were working with things similar to Mycobacterium tuberculosis in the lab, we had to get this test every 6 months. And so it would not be ideal to be getting a chest x-ray every 6 months, whereas they can just sort of quickly do this on your skin, see if you have the mark or not. And so generally, if you're positive, it means you either were vaccinated or you were infected. However, if you do happen to be a person with absolutely no melanin who gets these every 6 months, you can become allergic to it like everything else. And then you have to have arguments with healthcare professionals about areas of induration and arrhythmia and what you have versus what you're supposed to have and how this is actually fine. But yeah, I've had that argument. It leads to it's a whole thing. But yes.
What makes the TB vaccine for? We can discuss it after class. Like, you don't. Like, it's fine. It's fine. We can move on.
Send it a podcast episode.
It was made here's my short answer. It was made a really long time ago in a bunch of different labs. All tried to make it differently, and it was made a super long time ago, and so they made it in a poor way, and there's a lot of strain to strain variation. So it's not made well, and there's a ton of variation because it was made in so many different labs. Is the extremely short answer. Also, it just sucks. Okay. So in the remaining few minutes, I want to kind of introduce one last area. And this is an area that we're going to see come up a little bit more in the next couple of classes as well. So that's why I think it's important to sort of get going on it a little bit now. You can see, we've got these same mechanisms that are involved in a bunch of diseases, whether they're the allergies we've been talking about, the autoimmunity we talked about before, or the transplantation we're going to talk about next. All of these, as we've said, are examples of too much immune system. And so the other thing that we need to talk a little bit about is how we treat all this stuff. So I'm going to say a little bit right now about sort of general treatment. I'm probably not going to get all the way through all of the details regarding treatment, but at least I can get us into some of the mindsets of things we need to be thinking about with treatments. And we'll see where I go with stuff on Monday. So there's a lot of different treatments that one can use for autoimmunity, allergy, transplantation, all of this stuff. And one of those treatments that we can think about in either case, whether we're thinking autoimmunity or allergy, is treatment with steroids. And so you know about using prednisone, or you may have heard of using prednisone, which is a steroid. It's basically a corticosteroid to reduce immune responses. And so you can see this molecule, prednisone. has some similarities in structure to hydrocortisone, and it's like any other corticosteroid can lead to a lot of actions on immune cells. If you remember, I told you previously about the impacts of different hormones on immune cells. I told you about how estrogen and progesterone and testosterone all can act on immune cells. Really, all sorts of hormones can, including other steroid hormones. And as you can see with these corticosteroids, a lot of things are going on. We're seeing reduction in a lot of cytokine production, a lot of inflammation. We're seeing reduction in trafficking. We're seeing some apoptosis. We also are seeing some reduction in activation of lymphocytes. We're seeing kind of like a general, in a lot of ways, just reduction of the immune response with these corticosteroids. So there are two particularly important things to think about with that corticosteroid effect. One, there is another corticosteroid that sometimes, particularly say around this time of the semester, you might be familiar with. I see Miles snickering, so I'm going to ask Miles what it is. Miles, what one might you be familiar with right now? Cortisol. Why might you be familiar with cortisol? What's up with cortisol? It's a stress hormone. Turns out that as far as we can tell, stress generally dampens your immune system and generally dampens your immune response through these sort of general mechanisms. And there's lots of sort of interesting biology there that one can talk about. But the idea is sort of you get this general reduction of your immune response. And there are absolutely times where people with autoimmune disease or with allergies are treated with corticosteroids. There are a number of sort of issues with that. And I'm not going to get into like what's up with the kidney or anything like that right now. We're just going to stick straight to thinking about immunology on this front. There's a real issue with this treatment that we see here with corticosteroids. And the issue is that it is a very general reduction in immune responses. We're reducing innate cells, we're reducing adaptive cells, we're reducing everybody's action. Why is that a problem? Yeah, David.
Because reducing everything means that if you get infected with something else, you don't have that same level of immune response.
Yeah, so yeah, we're turning down your allergy, we're turning down your autoimmune disease, but we're also turning down your response to every pathogen. And so in fact, Emily asked about immunosuppression, and part of the reason why that was also hard to answer is because so many treatments that are used also mess with immunosuppression. You are basically taking that patient and just suppressing their whole immune system. You're not just suppressing specifically the bad response, you're doing this super broad blanket suppression. Now this is revolutionary for a lot of treatments. And we're going to see sort of this general theme of, in a lot of places, in a lot of biomedical therapies, the first treatments were super blanket for a broad aspect of the body, because we didn't know how to get more specific. With the immune system, we have this great, well, hold on. We got a little better with these things because then there was a drug, cyclosporin A. Cyclosporin is often thought about in terms of transplantation, but it can be used in some autoimmune and other disease states. We've actually already seen cyclosporin A. Remember, it blocks NFAT activation. So this one blocks only T cells and only NFAT in T cells. It leaves B cells alone. It leaves innate immune cells alone. So we've narrowed down significantly in that we're now only impacting T cells. You're going to be okay in terms of your antibody levels and things like that with cyclosporin. But we're still blocking all the T cells in your body, not just the T cell that's causing you problems. And so in fact, you are still immunosuppressed on cyclosporin. It's just you're not quite as broadly immunosuppressed. So we've narrowed this down. The reason why immunologists love talking about this stuff, this will be the last slide, and again, I could say so much more about it, is that we have realized, hey, wait a minute. We as immunologists, our problem in drug treatments is that we can't do things that are specific enough. We need to learn how to be more specific. We as immunologists have this whole system, the adaptive immune system, whose point is specificity. Its point is being specific. And so the idea is we can start to use different types of antibodies that we manufacture in the lab to get around serum sickness to actually attack exactly the cell we want to attack, to finally get us from this breadth in treatment to specificity. And so the use of antibodies to give us more and more specific treatments for a variety of different disease states has been kind of the reason why immunology is so very hot now. And that's something that we will do more after break. Enjoy your Thanksgiving. Eat lots of turkey.